Every single day, healthcare professionals accidentally violate HIPAA. Not because they are careless, but because they don't understand the difference between what you can share and what you cannot. Let me show you the one framework that changes everything. By the end of this video, you will know exactly how to identify what counts as protected health information, PHI. Get used to this abbreviation, please. Recognize when you can share patient information without consent, and avoid the most common HIPAA violations that end careers. This is the single big idea that appears again and again in hospital compliance training and real life practice. Here is the core idea behind HIPAA. You can only use or disclose protected health information, PHI, for treatment, payment, and healthcare operations. These are abbreviated TPO, or when legally required. The key facts you must know: PHI is any identifiable health information. This includes name, date of birth, medical record number, diagnosis, even facial photos. The minimum necessary rule: only access or share the minimum PHI needed to accomplish your task. Exceptions to consent: as a rule, any standard or rule in ethics has exceptions, and the exceptions are meant to protect or to provide safety. There is the rule and there are the exceptions. The exceptions to the HIPAA violations or the HIPAA disclosure are TPO, which is treatment, payment, operations; public health reporting; law enforcement with a warrant; emergencies; and of course, the patient himself has the right to access their own records. Hold on to those exceptions. They will guide you through the case. Now, let's look at the case. I need to create a realistic clinical case that involves HIPAA, so it's as close as possible to reality. And it shows how HIPAA can be easily violated during daily practice. You are a resident on the medicine floor. A 52-year-old male presents with fever, cough, and night sweats for 3 weeks. The clinical details show that he's febrile, he is tachycardic, tachypneic, with stable blood pressure and stable oxygenation. The lab work showed mildly elevated WBCs at 12,000 with lymphopenia and ESR of 68. The chest X-ray showed upper lobe cavitary lesion. You diagnose active pulmonary tuberculosis. Now, here is where HIPAA comes in. The patient's wife calls you directly asking about her husband's diagnosis because he won't tell me anything, and I'm worried. She provides his name and date of birth. The patient has not signed a release form naming his wife, and the patient is actually married to her. We verified that from the chart. You haven't asked the patient about sharing information with family. Pause and think. Can you tell the wife about the TB diagnosis? This is exactly how HIPAA violations happen in real practice. The trap is assuming family members automatically have access to PHI. They don't. The distraction is, but she is his wife. Marital status doesn't override HIPAA. The correct action is verify with the patient first whether they want family informed, or check if the patient has given written authorization. The question is not about being difficult, it's about protecting patient autonomy. So how to correctly approach this scenario? Thank the wife for calling. Explain you cannot discuss a specific patient information without permission. Offer to check with the patient about whether he would like family involved in his care. Document this conversation. As I said, there is always an exception. The exception is if the patient is incapacitated or in an emergency. You can use professional judgment to share with family if it's in the patient's best interest. And usually remember, your focus is the patient, not the family. The patient is your focus. What are the high-yield fingerprints for HIPAA compliance in the Step 3 exam? Buzzwords that should make you stop before sharing. Can you just tell me, stop, verify identity and authorization? I'm the spouse, or I'm the parent, the child. Check patient consent first. I need these 4. Stop. If this is legally required. Treatment, payment, operations, TPO. This you can share without consent. For example, discussing with consulting physician, billing department, quality improvement, things that are related to patients, the hospital's operations. The other exception is public health reporting. You must share TB, HIV, or any other reportable diseases. Family and friends, you need patient permission unless emergency or incapacitated. If the patient's on record, the patient has the right to access their record with rare exceptions. Minimum necessary information, and this term means what? If somebody from the billing department or somebody from finances or financial department in the hospital, they really need financially relevant information. They don't need the whole chart. So here, the minimum necessary information is to access the patient's financial and insurance records or information, but not the whole chart. Okay? Only share what's needed. Don't give entire chart when this chart summary suffices. For example, this is for the patient themselves. You really don't need to give them the whole chart. That's not necessary, and try to minimize the amount of information shared that way. It's a tip from somebody who has been dealing with these issues for a long time. In real hospital medicine, when I get a call from anyone asking about a patient, even if they say they are family, my automatic thought is, let me check with the patient first. I literally say, I appreciate you calling. For privacy reasons, I need to check with the patient about whether they would like me to discuss their care with you. Can I call you back after I speak with them? This is exactly what protects you legally and respects patient autonomy. 99% of the time, the patient says, yes, please talk to my wife, for example, and then you are covered. The one exception I make immediately is if it's a code blue or the patient is truly incapacitated and family is making medical decisions as healthcare proxy. Then I use professional judgment and share necessary information. Now let's go quickly over these scenarios. 1, a consulting physician asks about your patient's history for their evaluation. Can you share? Yes. This is treatment, part of TPO. Treatment, payment, and operations. Scenario 2, patient's employer calls asking about employee has been hospitalized. Why you has been hospitalized? Can you share? No. Employer is not automatically authorized. You can only confirm patient is admitted if the patient gave permission. 3, state health department calls about your patient's positive TB test. Must you share? Yes. TB is mandatory reporting for public health. 4, you can see neighbor's chart in the EMR, but you are not involved in their care. Can you look? No. Necessary rule. If you are not treating them, you have no need to access their chart. Summarize. The main idea, only use or disclose PHI for TPO or when legally required. Patient privacy comes first. Now, for the exam, pattern recognition of certain scenarios. Family member calling, has no authorization, stop and verify the patient with the patient first. Common trap. Assuming relationships automatic access. They are not. Clinically, this matters because one HIPAA violation can end your career, result in massive fines between 100 and 50,000 per violation, and destroy patients' trust. The three most common pitfalls to avoid: discussing patients in public areas, and this is very common, unfortunately. Elevators, cafeteria, nursing station, charts of patients you are not treating, even family and friends. Sharing information with unauthorized family without patient permission. This happens, but it's wrong. Shouldn't happen. If you want to build a deeper mastery of healthcare compliance, watch my video on informed consent versus informed refusal. What medical students get wrong. Next. It connects perfectly with today's lesson on patient autonomy and legal protection. And remember, when in doubt, ask the patient. It takes 30 seconds and saves your career. Now, returning to the TB patient, what you should do, the one that his wife called and asked about his condition. Go to the patient's room and say, your wife called asking about your condition. I explained I needed to check with you first. Would you like me to discuss your diagnosis and treatment with her? If the patient says yes, document in the chart, patient verbally authorized discussion of care with wife. Then call the wife back and explain TB diagnosis, treatment plan, and infection control measures. If the patient says no, respect his wishes, document patient declined. Authorization to discuss care with family. Explore why. Maybe there is domestic issues. Maybe he wants to tell her himself. But when it comes to mandatory reporting, regardless of patient's preference, you must report the TB case to public health department. This is legally required and not a HIPAA violation. This case shows the nuance. You can share for public health, but you cannot share with family without permission, even for infectious diseases.